Hello, and welcome to my health assessment teaching plan for the cardiovascular system. Um, what I kind of want to focus on is what I would do is kind of like a course overview, but this time I would just be focusing on the cardiovascular system. Um, what I want to begin with is a really amazing quote. Dr. Pappas said that nursing is the foundation to medical care. Nurses are the ones that assess their patients, and we let doctors know or nurse practitioners know when something is wrong and an intervention is needed. So that's why health assessment is so important for the patient and for the nurse, because we're relying on our assessment skills to take care of the patient. So we'll begin with the cardiovascular system. What I would do is I'm going to go over the content outline that I've laid out. First, we'll start off with history. So we're going to go over certain aspects that are important to both pediatric patients and adult patients as well. When you're first looking at a patient, if they're coming in for cardiovascular issues or not, you want to look at their chief complaint. What are they coming in for specifically? You also want to take into account any past medical history, any cardiac history, obviously. Something that's also important when you're looking at history, especially in pediatrics with infants that might have a heart problem, is their feeding. Are they feeding normally? Does it take them a really long time to finish? Do they get really tired? Are you noting any kinds of distress when they're feeding? Usually babies sometimes will get a little cyanotic if they're not tolerating their feeds because of a cardiac issue. Or sometimes they just get very tired. They don't want to eat again as soon as you think a baby would eat. So that's an important question to ask in your history assessment. You also want to look at psychosocial history and if they're on any kind of medications that could affect their heart. Past chemotherapy drugs can be very cardiotoxic, so that's something to think about. So to begin your physical examination, you just want to look. That's the most important thing to do before you put your hands on a patient and before you put a stethoscope. Just take a look at a patient. What's their general appearance like? Do they have good color? Do they seem to be laboring to breathe at all? Do they look tired? Do they look healthy? What do they look like generally to you? Then you kind of want to look, at their skin and their mucous membranes. Is their skin intact? Are their mucous membranes moist? Are they dry? Are they cracked? You also want to look and see what their color is like in part of their general appearance. Do they look pale? Is the color even from head to toe? What's their temperature like as you start to kind of, start to palpate the patient a little bit more? Do they have equal temperature throughout? Do they have different temperatures in different parts of their body? That could be a good indication of certain things. If inflammation in a certain spot, it could also be a circulatory issue as well. You also want to look at edema. In pediatric patients, you're going to look at periorbital and sacral areas of edema that might be indicative of some kind of cardiovascular issue. With adults, you typically look at their legs. If there's right-sided heart failure, you're going to notice that in the dependent areas of the body. You're going to notice more edema there. If it's unilateral, you're going to notice that that's probably a major venous occlusion, whereas if it's bilateral, that's probably congestive heart failure. If the edema does not have any kind of pitting, it's possible that could be an arterial insufficiency or some kind of lymphedema. So that's something to think about as well. When you're starting to look at the general appearance and feel things, are they diaphoretic? Are they kind of clammy? Are they moist? that is another indication of, maybe something's going on here in the cardiovascular system. Something that you don't always see, but in pediatrics you can see, in older adults you can also see, is clubbing of the fingers. Pediatric patients who have heart problems, who had, hypoplastic left hearts where they're chronically have low oxygen saturation, and that's normal for them, they're going to have clubbing of the fingers. Chronic desaturation is going to be noticed in adults too, so you're going to have clubbing of the fingers, which is something that's very apparent when you do see this. Something that's also important is in pediatrics is if the growth is normal. Do they seem to be meeting all their requirements in growth? Bilaterally, is everything equal? That's something also to look for in cardiovascular issues. So when you start to really, palpate the patient, you're going to look at the chest and the precordium. You're going to want to see, do you see any visible pulsations? That can kind of let you know if anything's going on cardiovascularly. You want to look at the shape and the contour, the symmetry of the chest, the breathing pattern, if they're having any difficulty breathing. Obviously, that could be a respiratory issue too, but it could also be cardiovascular. You also want to look for any kind of jugular venous vein distension or pressure. There's a way where you can measure the pressure using 2 rulers, and you're able to measure it from there. But if you have any kind of distension, you're going to see that. Especially if they're laying down, you're going to be able to see if there's any kind of distension. Let's see what else. Also, once you start palpating, using the ball of the hand on the chest, you're going to try to palpate for any kind of thrills, which are rushing vibrations in the base of the heart, between the 3rd and 4th intercostal space. You'll feel a rushing vibration, and that's known as a thrill. You'll also be looking for lifts. That could be a pulsation that's felt under the palm of your hand around the apical pulse. A lift is a pulsation, so you'll be able to feel that pretty decently. It would be a larger pulsation than the regular apical pulse. You'll also be feeling for a friction rub, which is like, it's like rubbing 2 pieces of material together, and you'll be able to feel that as well. Next, you'll want to look at peripheral pulses. There are central pulses that you're going to be looking for, your carotid and the femoral. You're also going to be looking for the brachial and the radial. For your lower extremities, your dorsalis pedis is on the top of your foot. You're also going to be looking you can look for the popliteal as well, which is on the leg behind the knee. And you can also look for posterior tibialis, which is around the foot and ankle as well. So you're going to be grading those. 0 means that you cannot feel the pulse at all. Just because you may not feel a pulse initially, you need to think about whether you're occluding it too hard, which is something you need to think about in pediatrics. You don't want to push on a radial or a brachial pulse too hard, because then you could be occluding it and you could be scared and thinking, oh, it's 0, I don't feel a pulse. But you want to make sure that you're gentle. But a 0 would be no pulse. That could be a possibility, especially in the feet, especially if you have a lot of edema. That could be a possibility. You really might not be able to feel a pulse, or it's going to be a 1+, which is very thready. Edema or heart failure is not the only cause of poor pulses. If you're getting shocky and septic, you're going to have pretty thready peripheral pulses. In my experience, when we had a patient who was beginning to go into SVT, and he started to really deteriorate, we could not feel any kind of peripheral pulses. Femoral pulses were even very difficult to feel. Those were a 0 to 1+. 2+, if you want to feel your own pulse on your radial artery, that's a 2+. If you're a healthy individual, that's going to be a 2+. That kind of gives you an indication of what's a normal pulse for a patient. 3 plus is very full. Sometimes you'll feel that when patients are tachycardic, maybe if they're on albuterol or if they're on, if they have sinus tachycardia, or if they're pathologically, having tachycardia, sometimes your pulses will feel full. 4 plus is bounding pulses. Those are full and bounding. You'll notice that with tachycardia, severe hypertension, you'll notice very full pulses like that. You want to make sure that all the pulses are equal throughout. There could be differences, with edema and so forth. So that's something to think about as well. Be careful to not palpate the carotid pulses simultaneously. You could cause syncope. And trying to really feel around for the carotid pulses, if you're really putting a lot of pressure, can cause a drop in heart rate and syncope. So be very careful about doing that. Capillary refill time, you can always do the nail. You can do it on yourself first to kind of see if it between 2 and 3 seconds is normal. You can also you'll be looking at your nail. You'll be looking at your extremities, trying to press on your hands and your legs and on your patient's hands and legs to see how quickly the bounce back is. Capillaries let us know how best your oxygen saturation is, how best your blood circulation is as well. Because capillaries are the ends where you have the greatest oxygen diffusion. So that's going to let you know it's going to be a good indicator for you. When you're having a hard time breathing, when you're starting to get shocky, when you're having any kind of cardiac issues, sometimes your perfusion is not going to be very good. So you're going to notice delayed capillary time. That's a very good indicator. When you see shocky or septic patients or other patients who might have cardiovascular issues, sometimes they're hypoplastic left hearts in children. Sometimes they're going to have decreased capillary time, sometimes 3 to 4 seconds. Next, you're going to start to want to auscultate. First, just take a listen to your heart rate and rhythm. Does it sound regular? Do you notice any pauses? You'll be able to count with a watch. You can count for 30 seconds. You can count for a full minute. And you can count, is this a normal heart rate for my patient? Obviously, in pediatrics, you're going to have and infants, you're going to have higher heart rates. In adults, you're going to begin to have more normal, slower rates between, 60 and 80. If you're assessing them, sometimes they're going to be a little bit nervous and they'll be a little bit higher. But, 100s to 120s is starting to get pretty tachycardic for adults. So that's something you want to count for and be assessing for as well. Next, you're going to want to do blood pressure. Obviously, a lot of places have Dynamaps where they're able to do it digitally. But it's also very important to learn how to do a manual blood pressure. And that's considered auscultation because you're listening. When you're taking a blood pressure, you're listening for the systolic and the diastolic blood pressures. On infants, especially if they're under a year old, you're going to want to take 4 extremity blood pressures because you want to see if there's differences in blood pressure. Sometimes that'll let you know if there's a change in blood pressure. That'll let you know if there's maybe coarctation of the aorta. If there's, in pediatrics, if there's difference in pulse pressures, sometimes that'll let you know of PDAs or aortic regurgitation as well. Blood pressures in adults, you're going to want to see, is this normal? Is this pre-hypertension? Is this hypertension? Do they take hypertension meds? At the same time, you also want to give adults and children a break with their initial blood pressure. A lot of people get very nervous, so sometimes you're going to have a very high blood pressure. So maybe as they calm down, if you get an initial high blood pressure, as they calm down and you start talking, maybe you want to take another blood pressure just to see if maybe it was just, white coat syndrome, they were getting nervous. Next, you want to check your normal heart sounds. Your S1 and S2 are the easiest heart sounds to hear. S1 is your mitral and tricuspid valves closing. S2 is the closure of the aortic and pulmonic valves. S3 You're not always going to hear that. Sometimes you can. It's a quick entry of blood into the ventricles. It sounds like Kentucky. If you hear a very loud S3, that's going to be pathologic. Though that's going to be an issue. S4 is the atrial contraction. It's hardly heard in normal children and adults. Sometimes you will hear it, maybe if they're very thin. It sounds like Tennessee. So that's something to think about. Oh, S3 and S4, I think about states, Kentucky, Tennessee. A very loud S4 is also pathological. Murmurs can be very difficult to appreciate, especially in pediatrics because they have such a higher heart rate. Sometimes it can be very difficult to hear. Sometimes if you use the bell of your stethoscope, sometimes you can appreciate it a little bit better. It takes time, but you're going to notice murmurs. It's heard because of a turbulent flow through an irregular opening or through an obstructed area. They're a little bit more difficult to hear in adults, and they do end up, sometimes people are born with murmurs that end up, being taken care of on their own. You don't have to do anything. And sometimes you'll live with them. But they're most easily heard in infants and pediatrics. So when you're looking for murmurs, you're going to want to observe for timing, intensity, location, radiation, pitch, and quality. Those are things that you're going to want to look for if you hear a murmur. Bruits, they can be also difficult to hear as well. A venous hum may not be clinically significant, but it could be seen in pregnancy, anemia, thyrotoxicosis, or it's possible in intracranial AVM. I have not personally heard a bruit for an intracranial AVM, but it is possible, perhaps in the adult population. I typically work with pediatrics. Carotid artery bruits, they're heard with obstruction, or they could be transmitted murmurs as well. They're more common in children. Usually you can hear them with vigorous left ventricular ejection. They're also possible with narrowing cervical arteries. So that's kind of an outline of what we'll be going over more in depth in a specific assessment class. Learning outcomes that we would go over, you just want to make sure it's scary for the first time, but you're going to build on those skills. And the more that you practice, the more that you're going to feel more comfortable using your health assessment skills. So specifically with the cardiovascular system, a student will be able to properly examine differences in adult and pediatric populations by focusing on history and physical examination through inspection and observation, which we went over in the content outline. Something that I think that is important that you start doing in health assessment, students will be able to identify normal and abnormal health assessment findings, and you'll begin to formulate how and when to notify these findings to the medical professional, whether they're the doctor or the nurse practitioner. Is this normal for the patient? Have they had a history of this? Is this an acute change? How would you document those findings, and how would you eventually report them? That's something to begin to start doing in health assessment. For teaching strategies, I really wanted to focus on this for my video, for my teaching plan. I was thinking the best thing to do, especially with health assessment, is practice. And I think students, especially bachelor nursing students, will feel more comfortable beginning slow and starting to hear sounds before they go to an actual patient. So we'll start off slow and we'll build up from there. There was a research study done by Decker and et al. That found that students who joined in cardiopulmonary simulation exercises achieved statistically significant pre- to post-test improvement in assessment skills and cognitive knowledge. So it's showing that simulation is very important. It helps with your self-efficacy. It helps with feeling comfortable with your assessment skills. something that I would want to do is I would want students to YouTube heart sounds. That gets you ready for what does S1 and S2 sound like. What does S3 and S4 sound like? What do bruits sound like? What do murmurs sound like? That way, your ear is better tuned when you start assessing patients. Like, hey, I think this is a murmur. I think simulation with a mannequin is very important. So in a simulation, you'll assess a simulation mannequin. You'll practice your assessment skills by asking questions, observing, palpating, and auscultating before you do the real thing. That way you feel more comfortable talking and assessing. That way you're not trying to think too hard of, oh my God, am I sounding right? Am I doing the right thing? That way you can really practice. So the way we'll do that is a case scenario will be given in the beginning of the simulation. You'll be split up into groups, and each group will participate in different areas of the cardiac assessment. Something to be careful of, be aware that not all the assessment findings will be normal. What are you going to do with those abnormal findings? So that's something to practice doing in simulation. How would you document this? How would you report this to a practitioner? Next, I have a very special simulation case study. Something that I see a lot as a pediatric nurse is elbow fractures in children. Something that you really need to be careful of with pediatrics and adults as well with a bone fracture is neurovascular assessments, compartment syndrome. And that's interesting because it doesn't really have to do with the heart, but how is it going to affect the perfusion in the arm? When you have serious compartment syndrome, usually you're going to be doing distal pulse checks. So if your fracture's on the elbow, you're going to be checking for a radial pulse. If you have a pretty decent elbow fracture and it's causing pretty bad compartment syndrome, you're going to start noting the color in the hand is different. The color in the nails compared to the arm that isn't broken is going to be wider. The cap refill is going to take longer. The pulses are going to feel more thready, like I was saying. So I think that's an interesting take on using your cardiovascular assessment skills in a different way. Not just focusing on the heart and your circulation. You want to focus on what other things could be causing problems with my pulses, with my color, with my temperature. So that's something to think about. You'll also be taking tests and quizzes based on just a review of your anatomy and physiology and assessment techniques and findings. But I think simulation is really going to be a good spot to really practice your assessment skills. That way you can practice before you go to an actual patient and put your hands on them and put your stethoscope on them. Those feelings of nervousness will get a little bit better if you're able to practice on simulation mannequins. Something that I also think is important, I wrote about this in my last paper. Pocket references are really good to have. They keep you focused during an assessment and they keep you knowledgeable. So what I would want to do is break up the class into groups, and each group would focus on a different area of the cardiac assessment and make a pocket reference for the rest of the class. That way everybody has their own pocket reference, we all worked on it together, and you can take it to your assessment. I hope you enjoyed my video for the cardiac assessment. I am looking forward to doing more of these and to doing more teaching plans. Thank you.